Absolutely. And Bernie, thank you and everybody from the Lehigh Valley Community Foundation and Embassy Bank for sponsoring this program. I'm thrilled to be with you. I wish I could be with you live up in the valley, but on Thursday evening, the majority leader changed the voting schedule and said that we all had to be down here Monday night for important votes. So that's why I'm in Washington and not with you in person. So just a few things. I thought I'd give you a quick update on what's happening in Washington before I introduce our good friend Nate Klein. But first, let me just say this. December is going to be a very wild month here in the nation's capital, as you can imagine. We have a few things we have to accomplish. First, we need a budget agreement so that we can establish the discretionary spending levels for fiscal year 18. I'm on the Appropriations Committee. We cannot really complete our work on the appropriations process until we have this budget agreement with the Senate and the White House. So we expect that to happen fairly soon, hopefully before December 22nd. And once that is completed, then we will move forward and pass the spending bills. We won't have time to do them all individually, unfortunately. That's largely because of the Senate can't move that quickly. So what will happen is we'll marry these appropriations bills together in one bill called an omnibus. And then we will pass that probably 3 weeks after a budget agreement is reached. We also have to take care of the Children's Health Insurance Program and ensure that program is reauthorized because many of our children do depend on it. These are children who are often low income but maybe not Medicaid eligible, and they rely on this for their health care. So we are anticipating that the Children's Health Program will also be authorized. This week, we must pass a continuing resolution to fund the government from December 18th to some point in the future. It will probably be to December the 22nd. That will be voted on as early as Wednesday. We also will have, of course, the continuing debate on tax reform. Legislation has passed both the House and the Senate, and the bills are different, and so they would have to be reconciled in what's called a conference committee. So the tax code, as you all are aware, has many serious problems. It's broken, 70,000 pages long. It's too complex. It needs to be made fairer and simpler. And so this whole debate is still raging. The business tax code in particular in this country is not globally competitive, and it needs to be updated after many, many years. So there are various aspects to this that will be discussed over the next few weeks on tax reform. So those are the major issues. One last thing I neglected to mention, and I know many at the Community Foundation and others have been very much engaged on the issue of relief to Puerto Rico. So we have to provide for a supplemental appropriation bill to help pay for the continuing disaster relief from the hurricanes that affected the people of Texas and Florida, Puerto Rico, and the American Virgin Islands. We still have a lot of work to do, particularly in Puerto Rico, where, as you know, the infrastructure was in a pretty difficult state before the storm, and it was decimated as a result of the storm. And restoring power and electricity is a continuing challenge, as well as for other basic needs for the people of that island. And we're trying to stabilize that island because so many people are going to be leaving and heading to the mainland. Many have already done so. They were already losing population for some time, and this problem is only going to be exacerbated by the storm. The financial crisis in Puerto Rico had also driven many island residents up here to the mainland, so we're trying to help stabilize this situation down there. So those are the major issues. I was also asked to discuss the situation at the VA. What I've been dealing with as a chairman of the Appropriations Subcommittee on Military Construction in the VA, I deal with a spending level of about $90 billion in discretionary spending. It's a lot of money. And largely what we're talking about here is veterans' health. Much of our spending is really focused on veterans' health, maintaining the very expansive veterans' health system where we have 152 veterans' hospitals around the country, like those, say, in Wilkes-Barre or Coatesville, Philadelphia, Lebanon, and elsewhere. We don't have a VA hospital in the Lehigh Valley. We have an outpatient clinic in the city of Allentown, a large one, but we don't have a veterans hospital. So there are these clinics that we have around the country, in addition, obviously, to the health system. One of the challenges that the VA faces is that many veterans today want to be cared for in the communities where they live. The VA health system is a closed system, so veterans typically were really not allowed to exit or leave the VA health system for care, other than for an emergency situation. But for scheduled appointments, traditionally and historically, veterans were required to receive their services within the VA healthcare system. But times have changed, as has the VA. You know, after the Second World War, our country decided that we were going to educate the returning GIs, and we did so through the GI Bill. And rather than create veterans colleges and universities at that time, the President and Congress decided that we would allow veterans to receive their educational services at America's public and private colleges and universities. It worked very well. And we educated a professional work class, and it essentially helped drive much of the growth that we saw in our country in the post-war era that provided for unprecedented levels of prosperity for the people of our country. And the GI Bill was in no small measure played a significant role in that growth and development of our nation after the war. And so, but on the VA health side, we took a different approach, as I mentioned. We have a system where veterans were cared for in the VA health system. And that was done in part because, in large part because we did not have a very expansive and robust healthcare delivery system in smaller and rural communities. Even in our own Lehigh Valley. You know, back when I was a kid growing up, I was born in 1960. And you know, we didn't have a Lehigh Valley health system back then, as an example. We had Allentown General Hospital, Bethlehem had St. Luke's, and Easton had Easton Hospital, but we did not have as nearly a robust delivery system. And now we have these, you know, wonderful and very sophisticated, complex health networks, whether it's Lehigh Valley, St. Luke's, Easton, or if you go out west in the Reading area, Penn State Health Systems. We have a lot of great health care now. And so what we're trying to do is better integrate the veterans and the civilian health systems. So if you're a veteran, say you're a Vietnam veteran and you're over 70 and you're living in Lehigh County and you need your hip replaced, chances are they'll send you up to Wilkes-Barre to have that procedure done. You know, if they can't provide that particular procedure in Wilkes-Barre, they'll send you to another VA hospital elsewhere, often in Philadelphia or New York City. Well, of course, you know, we can perform hip replacements quite well at many of our local institutions, as you know. And so the idea is to integrate these veterans into the civilian system wherever we can, and so that it's more convenient to the veteran and to his or her family. This is something we should be doing, where I've often felt that the VA health system needs to be much more focused on providing care to veterans with service-connected issues. So, post-traumatic stress, behavioral health, mental health, traumatic brain injury, Agent Orange services, those treatments. I could go through you know, prosthetic limbs. Again, issues that we know there are very real needs for our veterans population. And for other issues, you know, for example, OBGYN services. It's much better for the VA to integrate women in, you know, with a local OBGYN physician and perhaps try to deliver a baby in a VA hospital. So integrate them with a local OBGYN, and then have that veteran have her deliver her baby at a hospital where they deliver babies by the thousands, where they're very good at it. And the same can be said for maybe open heart surgery or oncology or other issues that maybe relate to aging. We can better integrate our veterans. In fact, today, nearly 1/3 of our veterans are receiving their health care outside of the VA health system. And the challenge for us in Washington and for the policymakers, the President, the Secretary of the VA, Dave Shulkin, who's a very good man and a Pennsylvanian and extensive experience in the health systems in Philadelphia. The challenge for all of us in Congress is that we need to ensure that we can maintain a VA health infrastructure on the one hand, and on the other, provide greater choice to veterans, simultaneously and sustainably. I don't think we're going to be able to do both of those well over the long term. I believe that we are going to have to pick a path, and I say pick that choice path, give those veterans more options to enter the civilian system for their health needs, and with the VA being more focused and specialized. That's a long-term problem we have to deal with, because the increases to the VA in terms of spending are much greater than virtually any other department in terms of percentage increases. Are very significant. And so we're going to have to get our hands around this and modernize this VA. And I'm very pleased to be working with Secretary of the VA, Dave Shulkin. He is very committed to this project. And it's not only there that we have some issues, we're also working very hard right now. In fact, we just entered a contract with a company called Cermer to establish once and for all an integrated VA health record. We are trying to make sure that when a member of the armed forces separates or departs or detaches from their time in the armed services, that health record can be seamlessly integrated into the VA health system. That is not the case. Oftentimes, a veteran will be asked, they'll be given a stack of papers, that high, to carry with them, upon their separation from the armed forces. So what we want to be able to do is make sure this is all electronic, seamless. We should have had this done years ago. A lot of money has been spent, unfortunately, without success. So we think we've got a plan to move forward over the next 10 years to integrate this system once and for all, so that a VA doctor can see electronically what the veteran's DOD health record looked like, and vice versa. So we're trying to do that, and hopefully we'll have this integrated with the civilian sector as well. So this is a major project that we are currently undertaking. It will take probably 10 years to complete this, but we think we found the path forward. We're using a commercial software, and as the Department of Defense has done, so we hope this will work out. So I hope that's a little bit of an update on some of the things I've been working on in Washington. I just wanted to wish everybody a very happy holiday season. Merry Christmas, Happy Hanukkah, whatever else you may be celebrating. And before I depart, I wanted to take a moment to introduce a very good friend of all of ours. You know him, I know him. He's Nate Klein. And I wanted to say a couple things about Nate.